Morning, doctor.
Hi, doctor. So, are we starting now? Hi, it's Mr. Ahmad, is it?
Yes,
Hi, Dr. Leong here. How can I help you today?
I I noticed my tremor, my hand
Mm-hmm.
tremor when I rest it
Mm-hmm.
initially, but now I also find I have difficulty when I hold the drink. I also spill them.
I see.
Yeah,
Must be very hard for you, very troublesome for you. Um, can you tell me how long has it started?
I noticed it 2 years ago, but I think the last
Mm-hmm.
week, I think it's just worsening.
Mm-hmm. Mm-hmm. Okay. When does the tremor get worse? Do you notice that any time that it is the worst during the day?
Uh, I don't know when I wake up and
Mm-hmm.
I'm resting, I find my tremor is worse.
Mm-hmm. Anything that make it better?
Uh, I don't think so. I don't think
Mm-hmm.
anything will in particular will
Mm,
be better. I
I
have
see.
not taken any medications yet.
I see.
I
In yeah, I see. In the notes that I have about you, it state here that you drinks about 2 drinks of alcohol per week. Is that correct?
Yes, I do drink, but not every day.
Mm. Mm-hmm. Do you think after drinking alcohol, the tremor become less?
Uh, no, I don't think the alcohol helps in relieving my tremors.
Mm-hmm. I see. So you mentioned that it is on your arms. Is it both sides?
I started in one arm, but
Mm-hmm.
now slowly also affects my other arm, I think. But my worst
Mm-hmm.
arm is my right one. But
Mm-hmm. Anywhere else that is involved?
uh, I don't have any other shakes
Mm-hmm.
anywhere else. The
Mm-hmm.
worst is my right arm, and now slowly my left arm is also affected.
I see. Do you have any, do you feel that your heart is beating fast and sometimes you feel that you cannot take, you feel that all the time you're feeling hot? Does that happen to you?
I don't understand, doctor.
Do you feel that your heart is beating fast sometimes?
No, no, no,
No,
no,
yeah. Do you feel that hot weather disturbs you more than the cold weather?
not really.
Not really. Does anyone mention anything, any changes over your gait, the way that you walk recently?
Yes, they say I'm walking a bit slow now,
I
and
see.
I don't smile as much as before.
I see. Anyone mention about the way you talk, your speech, any changes?
Yeah, they say I talk a bit slow now.
I see. Do you take any medications or do you have any medical illness prior to this?
Uh, no, I don't take any medications except
Okay.
aches
Mhm,
and pains. I take Panadol if I have pain, but
mhm.
otherwise I
I
don't take
see.
it.
All right. Um, I ask this question to all my patients. Do you take any illicit drugs?
No,
Okay. Do you drink any coffees, any caffeine drink?
I do drink coffee, but not maybe once or twice a week.
Once or twice. All right. Do you have any because stated here your mom has diabetes and your father passed away because of heart attack. Do you have any family history of like Parkinson's disease?
Uh, I don't remember,
Mm-hmm.
doctor, but what is
Mm-hmm.
Parkinson disease, doctor?
I see. Okay. Parkinson disease is a neurodegenerative, meaning that the part of the neural system, the nerve system in our body and our brain is degenerating. So
Oh,
sometimes it might cause some problem to the patient, for example, shaking, tremors, a bit rigid over the movement.
do you think I have Parkinson's?
Yeah. Well, there are a few causes that might cause your issues, but to be honest, the over top of my list is actually Parkinson disease.
How do you treat me, doctor? Will I get better?
Okay, so Parkinson disease is actually a progressive disease, meaning that it will progress normally from better, it will become worse over the time. But with the modern medicine now, we have a lot of ways and a lot of medication that we can give you to help control the symptoms and to improve your quality of life.
Oh, so
Yeah. Are
so
you? Oh, yeah.
what medicine do you think I need medicine now for my shaking hands?
Okay. For now, because my top diagnosis is Parkinson, I would refer you to the neurologist for further confirmation of the disease, and then from there is medications that we can help you with the shakings and all. Would that be okay with you?
Yeah, anything will help, but what
Mm-hmm.
is the medication you're going to prescribe for me?
Um, Probably what we call a levodopa. It's a dopamine. It's a medication which increase one of the chemicals in your brain. We call it dopamine, which might help with all the symptoms that you are having.
So
You,
how long do I have to take it?
um, I will have to get back to you on that. But in meantime, do you think that any what are the things that is affected most in your life that we can help you with? This,
So I'm
yeah,
only scared whether I can drive.
you can drive. I see. In this case, normally I would advise for you to avoid driving first now until you are being reviewed by a neurologist. And then from there, we can assess whether you are suitable to continue to drive. Because you see, Parkinson can affect our movement, and it has already happened to you. And sometimes all this movement might affect our function in driving. So for now, probably it is to be safer. I will advise you to avoid driving, and we will assess from there. Is it okay?
Okay, doctor.
Yeah,
How
yeah. And
many?
then I will, yeah.
What are the side effects if I take the medication? What will happen if I take the levodopa? What will happen? What are the possible
Positive
side?
side effects. All right, very good question. For some person, they might have very mild symptoms like nauseous, vomiting, and then some discomfort. Some might have a little bit of abnormal movement from the medication, but don't worry about it. We will monitor about that. And in some cases, after you have been taking for a very long time, um, there will be breakthrough, like the tremors will come back on and off. So don't worry. Also, we will monitor on that. Is it okay with you?
Yes, doctor.
Yeah. And then other things that I can help you with today is if you do need supports, because some person that has all these chronic diseases, especially Parkinson, their mood will be heavily affected. So if you do have problem with that, we do have some support groups that we can refer you to. And then I have some pamphlets here where I can give you to read about this disease and what we can do for you. And other things that I might refer you to is, for example, occupational therapy. Um, they can help you with some modifications during your daily life to make your to help you to carry on your daily life a little bit more better. For example, you tend to spill your drinks quite often, right? So we will try to modify the cups for you and teach you how to use it more effectively. Is it okay?
Yes, doctor.
Okay. Probably next appointment, I will see you back in around 2 days. And it is very good that if you can bring along your family members and we can discuss about this matter a little bit further. Is it okay?
Thank you, doctor.
So,
Can I share the screen for the thing?
Yeah.
IT support. Can I share my screen now?
Sure,
Yes,
Dr. Lee,
sure.
go ahead.
So she done very well for the case. It's actually a Parkinson disease. I just like to share this screen with you. So can you all see the
yeah,
screen?
yes, doctor.
Can you see the screen I have here?
Yes.
Can, doctor.
All right. Can you see this? I've done this slide. So this is a case on tremor. Tremor is a neurology thing, but it could come out. I guess it's good to share the experience, and that's a history. So very noticeable that the tremor is at rest. So when it's at rest, it's one of the tremors. The other essential tremor. So among you must know the common tremors. So Parkinson essential tremors, and also medication induced. So in any tremor, the first thing you must do is that you make sure that it is not any other involuntary movements. So you must exclude involuntary movements. Because sometimes like chorea and all that, they can present, but their frequency is they're a bit slower in choreiform movements. So the step one is just to make sure that step one is make sure it's tremors. Step two, you must know the common things. The common things will be Parkinson's, essential tremor, sometimes mental stress, which the candidate has answered, and medication induced also the answer. So all four were covered in her history taking. And then you have to confirm the history and examination. So I've done a mnemonic for tremors, but this is for a full list, eye tremors, that you can actually go through it. TRE and then MORS. These slides will be sent to all the candidates who have given their email, and we'll send all the slides to them. Happy to share with you. The last one is on cerebellar tumor. So these are common tumors, common tremors. So common tremors in Parkinson, just for a short thing, is progressive. What Mr. Ahmad is progressive. And akinesia. So bradykinesia means that you take your arm, you do this, you ask the patient to do this, Okay, and it should be at the same amplitude. But in Parkinson, they do fast, and then they do slow and slower and slower. So that is how you can actually elicit Parkinson's amplitude getting slower, like akinesia. And ask the action tremor will cease the tremor, and the patient can draw and make an Archimedes spiral. So a lot of A's, R for rigidity and rest. There's no kinetic. So kinetic is this postural tremors, the postural tremors like this, and the other one is this. You can do your tremors this way as well. And action tremors is doing the finger nose testing. And then no action tremor, shuffling gait, and it's got a mask-like faces, so it doesn't smile. But a lead candidate, it's difficult to get a full history, but sometimes you can get the non-motor symptoms maybe precede all these Parkinson's symptoms by 1 year. So they got anosmia, anxiety, and the constipation and depression as well. So these are non-motor symptoms, which are also a feature of Parkinson's disease. Essential tremors, so both of them are inherited, you can see, but this is more common. It's 1% of the population, and usually in the upper limb, and then goes to the head and the voice. and they got very soft neurological signs. So ESS, EN, no rest tremor, they treat with propranolol usually. And there are two ages that they count essential tremors, after 24 and after 46 years. And alcohol, which the doctor has asked for, alcohol will resolve the tremor in about 2/3 of cases. And then mental health, also they must ask, which you have asked in the exam. So these are the Archimedes spiral tests we can read up later as I given you the slides. You can go and read about it. We don't talk much about rare tremors, but you can go through it. But they're not commonly seen in general practice. But we always think commonly. So history taking, I always like the Socrates mnemonics. So I'll go, this you follow accordingly. History taking is basically reinforcement of your what you see in the history. So looking for the areas involved, whether the hand when it's resting is shaking, or action you can demonstrate by this finger spread apart and this as well. And action tremors. Frequency, you can make out a slow and a fast tremors, and then a full neurological exam just to exclude other things other conditions that may be affected, may be associated with Parkinson and other neurological conditions. Treatment of tremors, you can treat tremors with propranolol, but you must be careful of bradycardia, bronchospasm, and hypotension. Primidone is not available even in Australia. Can't difficult to get. So you get essential and dystonic upper limb tremors. Topiramax is very good they use it for migraine as well in Australia after the CAPS, candesartan, which is ARB, and then the NDET, propranolol, and also Centromigraine is first degree for migraine, but Topiramax can use it. But Topiramax, once you go above 100 milligrams, 50% will get paresthesia. Topiramax suppress the appetite. So patients are happy because they lose weight with Topiramax. So the patients love Topiramax. Only that does cause a bit of cognition and issues. And also because it's central acting. So you mentioned levodopa. In Australia, we do prescribe levodopa even without the neurologist. We do prescribe. And these are all they decrease the peripheral decarboxylation, benzodiazide and carbidopa, and they do cause a bit of nausea and lightheadedness. Artane is the only one also I use. So normally they start with pill rolling movements, then later on they develop. But it's a well done case. The candidate has done well, and I'm very impressed with her as well. Shall
Thank
we
you.
go to how is the time? All right, or shall I? We'll go to case 2, or is there any? Is the time? Is the 10 minutes up? It's still 5 minutes, is it?
No.
How much do we have time to discuss, or? I hope I'm not rushing too much, but if there's enough time, we go on. But otherwise, if the time is a issue, we go on to case 2. But we can always come back when we have enough time for everything. Is that all right? Or anybody wants to ask some questions now? There's a chat here that comes up. Nobody has written anything. Just say that everything. A lot of people are unable to join. Okay. So shall we move on to case 2? Who is the doctor next?
Hi, doctor. Jaya.
Jaya, how are you?
I'm good, doctor. Thank you. How are you?
Good. It's winter here.
Okay.
Shall we
Yes,
start?
doctor. Can.
5 minutes here. So Parkinson is good. It's good to go through. Sometimes they do come out. And also it's good for your practice as well. But in Australia, sometimes I use Artane. Artane, they use it for, in psychiatry, but I do it for patients. I start them on, but it's got anticholinergic side effects. If the patient has got asthma, COPD, then sometimes we can't start them on. That's why I put them on Artane. But in this case, it's valid to start levodopa because it's already affecting his movements, So he can't even drink coffee, So it's appropriate. Dr. Leong has appropriately said that he should start levodopa. In Australia, we start even without the neurologist. If you're confident, we can start the.
Okay, Doctor.
Malaysia a bit more. We tend to depend a lot on neurologists. But in GP, in here, rural areas, regional areas, we start them on. Okay, so shall we go to?
Okay, are you ready?
Yes.
That's ready. Okay.
can start. 10 minutes starts now.
Good morning, doctor.
Hi, good morning, Mr. Sam. All right. What brings you here today, Mr. Sam?
I think I've just got blood test or something with it for the
Yes.
is that a
Okay.
blood?
Yeah, we'll get to that, Mr. Sam. Before that, I would like to just like to ask you a few questions, if you don't mind. So, is that okay, Mr. Sam?
Yes, doctor.
Okay, all right. Mr. Sam, you've been diagnosed with diabetes for the past 8 years. How are you taking your medication?
I take it regularly, only twice a day.
All right. Do you do you miss any medications, or do you have any problem with the medications?
Just take in the morning and before I have my dinner and before my breakfast.
All right. Okay. Very good. Apart from that, Mr. Sam, have you been experiencing any problems recently, like any physical problems? Do you have any chest pain, or do you have difficulty doing things that you used to do before?
No, doctor, I'm very fit.
Okay. Good. Good. Okay. Other than that, do you have any leg swelling? Have you noticed any difficulty sleeping? You need more pillows, anything like that?
No, I'm very good. I'm
Okay.
healthy, doctor. I just thinking whether I need a blood test or not.
All right. All right. Okay. All right. Other than that, you have any other problems at all that you'd like to tell me?
Not really. I'm just worried my diabetic and whether my diabetic will affect me because I'm still pretty young, 53 years
Yeah,
old.
yeah, of course. No worries. We'll get to
Think
that.
whether I will die early because of my diabetic.
All right. Okay. Mr. Sam, just a bit more history I'd like to get. How's your diet like on a daily basis?
I eat quite well.
Mhm.
My wife cook for me, so it's quite healthy diet.
All right. What about physical activity? How are you with physical activities?
Just
Are you
do
active
treadmill, just run about half an hour on the treadmill.
daily
Not run, I walk. I only walk on the treadmill.
on a daily basis?
Yeah, I think most days, especially the weekend, I walk a lot. Weekdays,
right.
I don't do so much because of work.
Mhm. Mhm. I see here that you don't smoke at all. That is very good. And also you don't take any alcohol. Other than that, sorry to ask you this. It's a routine question that we ask. Have you tried using any drugs or other than
No, no using drugs.
recreational drugs? No. Any traditional medications that you're taking other than what we are giving you?
No, I
Any
just take
supplements?
sometimes the rub, the palm oil rub just rub something if I have pain. Otherwise, I don't
All
take.
right. Nothing else lah, huh? Okay. Well, what about any other stresses that you have? Do you face any problems at work or at home?
I work in the bank for nearly 30 years already. I'm okay.
All right. Okay. 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 Very good. So we will get to your investigation. Just before that, do you have any idea what's going on? Like, what are you expecting in your results, or if there's any particular concern that you want me to address during our session today?
Have you got my blood test results today? Do you have them?
The
Yeah. The old result, do you have them or you're going to order one for me, is it now?
Okay, what I have here, what is given here, what I have today is your HbA1c. Are you aware what is a HbA1c?
Yeah, it's the long one, isn't it? The long report.
Correct. Correct. It is basically telling us how is your diabetic control, how has your diabetic control been for the past 3 months. And that result shows 7.1. I will get to the details of that in a bit. Other than that, I have your blood pressure here, which is 136/78, which is fairly well controlled. And we also have your urine test, which showed that it is good because there is no albumin. Albumin is a type of protein. There is none of it in your urine, so that is also actually quite good. I also have the result of your kidney function, which is a 90. That is also good lah. So far, this is what I have. Is there any other investigation results?
It's my cholesterol result with you, not there.
No, it's not given here. It's
So my cholesterol result, I think is they say something about my cholesterol. They say my triglyceride is very high. I
Okay.
think. Oh,
Is
and
there another page to this? Because I'm not given this, the results are not here. Okay, all right, okay. Sorry, Mr. Sam. Yes, yeah, now can see, yeah. Okay, so coming back to your results, Mr. Sam. Yes, I do have your cholesterol results. Basically, other than what I've mentioned earlier, your cholesterol results are not the best lah, huh? Your total cholesterol is 5.3. Generally, we want it lesser than 5.2. Your triglycerides, which shows basically yeah, your triglycerides shows 2.1, which is also not a very good number lah. Ideally, we want anything less than 1.7. LDL, basically that's a bad cholesterol, we call it in layman term. Yours is 3.5, which is also not too great lah. So yeah, we'll come to that in a bit. So far, do you understand? I know I've been throwing numbers at you. Are you with me? Do you understand what's going on?
Yes, doctor, but is there any? I think I should take. Do I think I need to take cholesterol medication for this?
Yeah. All right. Getting to that. So what you have is what we call dyslipidemia. Basically, it's just a medical term to say that your cholesterol levels are not very well controlled lah. All right. In your case, since you have diabetic and you've had it for the past 8 years, you fall under the high risk category. A high risk category means your risk of developing a cardiovascular event in the next 10 years time lah. Yeah, so in your case, it is advised to start on medication. I would for you, I would advise to start on a statin, a low dose statin, atorvastatin. Apart from that, the statin is going to help you bring down your cholesterol levels. But other than that, yeah, at the same time, other things that you can also do is of course incorporate exercise and probably a more balanced diet. I understand you mentioned that your wife cooks for you, so maybe this is something that you can probably explore further with your wife. I can later on give you some pamphlets. You can look into Mediterranean diet. Diet that focuses on good cholesterol rather than the bad cholesterol. It's also contains low simple sugar and low calorie, so that also can help you bring down your bad cholesterol levels lah. Other than that, good that you mentioned that you're doing regular exercise. 30 minutes a day, 5 times a week is the recommended meaning the recommended time for an exercise, which you mentioned you're doing very good. Keep that up. So as far as the medication is concerned, like I said, it's very good if we can start you on a statin, atorvastatin 20 milligram. There are some side effects. Some people might have some muscle pain, or in a severe condition, but it is very rare. But in very severe condition, they may have some liver problems, but rest assured, these side effects are very rare, and their benefit far outweighs their risk. And if at all you do develop any of these side effects, do come back immediately. We can see what we can do about it. Other than that, I would also, upon starting your medication, I would also see you back in about 1 to 2 months' time. We will repeat your liver function test to see if you agree with the medication, and also your lipid profile to see if there's any improvement. Another aspect that I would also like to touch is, of course, your diabetes. It is not bad, but it can definitely be much better. Currently, your HbA1c is 7.1%. Ideally, we want to bring it down to 6.5%. Yeah, and apart from that, I'd also schedule you for a diabetic food examination and a fundus camera. Basically, what we're doing is we're checking your food to make sure you've not developed long-term complication of diabetes, and also checking into your eyes to make sure you don't have diabetic complications to your eye. Anything else that concerns you, Mr. Sam, in particular you want me to discuss during our session today?
I think we run out of time.
Are you sorry?
It's quite good, very good. But yeah, so we'll just share screen again, then we'll see what I've written down. So can I share my screen again?
Yeah, sure.
So you must turn off it. Yeah. And then I share. Can you all see now? Can you all see?
Not yet, Doctor.
Not yet. Can you see now?
No.
Still no.
No.
Mm. Can you see now?
Okay.
Can.
All right. So this is diabetic. So the thing is diabetic dyslipidemia lah. So yeah. So 113. His blood pressure 136 is actually is considered high normal lah. So it's 130 to 139 is high normal. I think it could be improved lah. That this one is good lah. 78 less than 80 is optimal lah. So we have two different categories here. 136 if you look at the classification of hypertension, is classified as, so there's optimal, there's normal and high normal. So this is less than 139, so it's still high normal, and that is normal. That's optimal. But when you have two different categories, so the lower category applies. So in conclusion, is high normal. It can be improved because historically it can get with exertion or with anxiety as well. 7.1 is not really that good. So if you convert it to RBS, it's times 2 minus 6. So you convert HbA1c to blood sugar times 2, there's 14 minus 6, about 8 millimoles. The cholesterol is the one of interest. HDL, you cannot do anything. It's only by exercise. There's no medication. LDL is a very interesting thing to talk about. So in any hyperlipidemia, if you notice, you must exclude secondary causes like hypothyroidism, obesity, nephrotic syndrome, diabetic as well. Then familial hyperlipidemia, I've said so much already. It's 1 in 250, 1 in 300 candidates, patients in the population. So you can diagnose by point system using the Dutch Lipid Clinical Network criteria, patient history, family history, clinical exam, looking at the arcus senilis and tendons and thomas, and looking at the LDL levels. Then you can divide by this. Because familial hyperlipidemia will not respond to anything except you won't respond to potent statins. You can only respond to the PCSK9. The PCSK9 is, you can reduce the cholesterol by about 50 to 60%. Then hypercholesterolemia, step 3, some of them they can have. Step 4 is just hypertriglyceridemia, but the cholesterol is normal. Then 25%, this is the most common one. So this is where we get diabetic dyslipidemia. It's a bit of insulin resistance, causing low HDL but high triglycerides. Okay, so this is an example of the hyperlipidemia levels. And 0.9 in men, 1.1 in women. So the step 1 in cardiovascular, you must have, Malaysians, you all do cardiovascular risk. You all use risk calculator or not? Jaya? Do you use
Flemingham's Corner.
what's your 5-year or 10-year cardiovascular risk? In Australia, we use the cardiovascular 5 years. We look at eight factors. So the age, then the 3 S's, the sex, the systolic blood pressure, then the smoking status, the diabetic status. Then we look at total and HDL cholesterol. Then we look at the ECG to see whether it's got left ventricular hypertrophy. From there, you got green, amber, and red. So if it's 5%, we do lifestyle. And this one, if it's 5 to 10%, then it becomes a difficult decision. Then we have to do, you may talk to the candidate whether they want calcium score, which is not really that predictable. lipoprotein A, lipase. So this is a difficult group, the yellow group. When we say moderately potent statin, what do you understand, Jaya? What are the potent steroid statins you use? Only two potent statins you use. One is the dosage in atorvastatin must be at least 40, 40.
40, yeah,
But in rosuvastatin, Crestor is actually half,
20.
so 20.
Yeah.
And you can take it any time of the day because it's very long half-life. These two are very long half-life. Unlike the traditional simvastatin, they must take it at night. This one you can take it at any time of the day, a long half-life. So when you say moderately potent, that means it must be the either atorvastatin 40 or rosuvastatin 20 milligrams at least. And so it's basically that. I mean, I think once it over 4.9, then there is a problem. In this case, his LDL was how much just now? About 3.5 a day.
3.6.
3.6. So I think actually 3.6. His one is really according to the. I mean, it doesn't. This thing doesn't apply to diabetics, is it? This formula, you can read it in up to date. Is they give you that sort of algorithm workout, but this algorithm doesn't apply to diabetic because diabetics they don't die of diabetes. Diabetes they die of a heart attack, So that's why we need to be very proactive in lowering the LDL. You must understand that LDL is a surrogate to heart disease. And the HDL, you see, this guy is pouring the cholesterol. This HDL is trying to get rid of it. This is the devil, and that's the angel. So, how I remember is H is a high distinction cholesterol, so it's a good one. But this one is a low distinction, is a bad one. So it's a surrogate, and you should work on lowering the. So they don't concentrate even in diabetic dyslipidemia. We don't look at the HDL levels, because HDL levels we can't do anything about it, triglycerides. So we try to lower the LDL. If he's not diabetic, we can use this algorithm. I would probably, like you said, I would start him on 20 milligrams as what you mentioned. But if you do head-to-head studies, rosuvastatin is more potent than atorvastatin. Head-to-head studies. So the most potent is, but if it doesn't work, then what do you do? If it doesn't work, you can't lower, and you do 6 weeks later, you don't meet the target, what do? You add on eczacimide. Eczacimide is Ezetrol 10 milligram because it works different ways. It works on the intestine, whereas this one it works on the cholesterol on the liver. They block the enzyme, so it's different. So eczacimide will lower by about 10, 20%. They can lower it. And that doesn't work, then you put the last resort. Then you got to find out whether he's taking his medicine. You look at the last. I always use the last mnemonics. Lifestyle. Lifestyle has to be there, so you must impose lifestyle. Like that's what you said earlier. A is for adherence or compliance. Then as you look at other causes like secondary causes. And T is whether there's any therapeutic inertia, whether people do take. So sometimes it's high, but people don't bother about it, just let it go on. And then, so these are the last mnemonics is always, you can use it in uncontrolled diabetes, uncontrolled asthma, uncontrolled hypertension, uncontrolled hypercholesterolemia. You always go back to basics, LAST. You find out the lifestyle is either smoking, nutrition, alcohol, physical exercise. You use this mnemonic, you can actually find a solution as to where went wrong in any chronic disease. LAST. See whether there's any question. I'll turn this off, but I'll send again. I said I'll send this to you. So the IT can come back to the scene again.
Okay.
I can come back to the scene now. And if the 10 minutes is up, you go on to case 3 now.
Good evening, Dr. Chen.
Uh,
I'm Wani. I would like to ask a few questions. Is it okay?
yeah.
Ah,
What's your name?
Okay, I would like to ask about this station. What is actually the nature of this station? Are you actually expecting the candidate to explain the results, or is it like
This is a interpretation of all, and then basically a healthy lifestyle wants to ask you what sort of advice you will give the patient, and also interpretation of the results as well. So you will have to explain the results and then tell him what are the things. That's what Dr. Jaya did to improve future and decrease the mortality in his scenario.
okay? Because during the initial part, we were not given the result first, so I was wondering.
A bit of mix up.
Okay, all right.
A bit of mix up because this all was organized about 1 week ago. So
Okay, that's fine. Thank you so much.
writing this case in the airport when I was flying back from Malaysia.
Okay.
Flying back,
All right,
yeah.
thank you.
Yeah. So, but if it is a proper exam, they'll be much more organized than me because this one is a bit. We didn't have any practice session, so we went straight ahead. But in the real exam, they will have the real they have a lot of practice. So by the time the candidate, they make sure that the candidate will not be, disadvantaged if you give them the wrong findings or. So don't worry the real exam is different. Are we right for the third? Who is a volunteer for third?
That's me, Adina.
Oh, Dina. How are you, Dina?
I'm good, thanks.
Good. And this one is should be quite easy case, I think. Let's see. You're able to read the thing now?
Okay, Dina, are you ready?
Yes.
Okay, so this is no case, no sort of like, it's no consult, it's just asking you questions about it, which may come out in the discussion exam.
Yes.
So basically, this lady Elsa is concerned about her risk of osteoporosis. So basically, what sort of risk factors will you elicit from her? How do you ask a history of like if patients comes to you and ask you about
Okay.
she's worried because her neighbor, suddenly died of a hip. After she got osteoporosis, she fell down and then she died 2 weeks later after she diagnosed. So she wants to know about, maybe she has osteoporosis as well.
Right.
So,
So other risk factors that I would like to elicit, if there's a previous history of osteoporotic fracture or low trauma fracture, for example, Colles fracture, hip fracture, if there's any family history of osteoporotic fracture in one of her parents, if there's any use of a long-term of corticosteroid in the past, and then I would also, it's in the history already that she's a smoker. And then I would like to know specifically her BMI. If it's less than 16, then it is a significant risk for osteoporosis. And I also would like to know, is she on any calcium or vitamin D supplementation at all? I also want to know her age of menopause, and also whether she has taken any hormonal therapy in the past. And then I would like to know about her COPD control as well. Whether, like if she has like multiple exacerbations requiring prednisolone, I think that's significant as well. I also would like to know how, is there any risk of falls that may make her prone to fractures? So I would assess her risk of falls as well, whether she's using any walking aids, what's her vision like, whether he had any history of falls before or a history of near falls in the past. I think that's about it.
So do you think with the amount of exercise she does, is that all right? Is that good to prevent osteoporosis? She swims regularly in the pool, but she doesn't do anything else.
Right. So swimming is actually considered a mild intensity exercises. So I think she need to add more like resistance exercises, for example, like muscle strengthening, like weight resistance exercise involving all the limbs, and then do more moderate intensity exercises, for example, running or jogging, minimum of 30 minutes, at least 5 times per week.
So in her case, what will be the risk factors here? She's a smoker and she's also drinks, isn't it? Yeah.
She's a smoker. Her age, she said she's underweight, but I'm not sure what's her BMI is. And then I need to know whether she's
What investigations would you order for Elsa?
Investigations I would like to order. I would like to order her. I would like to know her full blood count just to see whether she's anemic or not. I would like to order thyroid function test, because if she's like a hypothyroid, that could put her at risk of osteoporosis as well. I would like to measure her vitamin D and calcium levels as well. And then I would like to assess her, do other investigations, just to do like a cardiovascular screening as well, like checking her renal function, her liver function test as well, and also assess her lipid profile as well.
So what are the secondary causes of osteoporosis apart from thyroid? What else can cause like secondary osteoporosis?
Could be like prolonged use of corticosteroids.
Usually they say 7.5 milligram even for 6 weeks, you can get it as well. Minimum of 7.5 for 6 weeks, you can get it. Even for 3 weeks, they say you are prone to osteoporosis.
Okay.
So the other secondary will be actually hyperparathyroid, celiac disease, and even multiple myeloma. These are the secondary. So you proceed with a DEXA scan. Can we have a DEXA scan? Yeah. So it comes out like this. So what is your diagnosis then?
One moment. So she's 68 years old. So indeed she's for the
Where's the T-score here?
The T-score so this is the femur. So the T-score is the right femur is -2, and the left is just above -2. So I think it's less than -1. So she has osteopenia. But I would like to calculate her FRAX score as well to see her risk of major osteoporotic fractures in the next 10 years.
What would you do for her then? How do you manage her? She's not osteoporosis.
So at the moment, I would advise her I would supplement her with calcium about 1,200 milligram per day, and also vitamin D 800 units per day. I would advise her to continue with her physical exercises, with resistant exercises, muscle strengthening exercises. And then I would also advise her on falls prevention advice to avoid any fractures, and which includes form-fitting footwear, advise her to go to physiotherapy for balance training, for muscle exercising, occupational therapy for home adaptations, and also correct her vision if needed. And then I would also advise her on adequate exposure of sunlight, and then also ask her to stop smoking if possible, because I would assess her readiness to stop smoking, and then depending on her readiness, whether to give counseling or start pharmacological therapy, and also advise her on the alcohol intake, to, if possible, to stop alcohol or cut down slowly. And then I would also ensure that she has a good control of her COPD as well, make sure her medication is optimized.
What happens if you have to start bisphosphonates, say she had progressed to osteoporosis, and you look at her medication, she's on tiotropium and antacids, So how would you advise Elsa if she's taking, say, alendronate? How would you advise the patient, Elsa, if she takes the alendronate?
So if she has occasional GERD, then maybe oral biphosphonate is not suitable for her because it can cause reflux esophagitis as well. So I probably would consider something like IV zoledronic acid, which is probably more suitable for someone with GERD. So this is done with conjunction, I mean, with a co-management with the orthopedic department as well.
So what are the two? What are the side effects with zoledronic acid? What sort of effects would they get?
I'm not sure, to be honest.
Yeah. So you can get the same thing, osteonecrosis of the jaw and atypical femoral fracture, but some of them they develop what they call acute phase reactions that can occur within the first 2 days of the IV injection. But the advantage that they can do it for 1 year. Okay, now this wants to talk about she had flu and she had COVID now. The next question. So she wants to talk about other vaccination for her age. What would you recommend?
Right, so for her age group, and also because she has COPD, she should consider the pneumococcal vaccination and also the COVID-19 vaccination. Other than that, she could also consider the varicella zoster vaccination as well.
So which one will you give advice her if she's happy to pay? Which zoster vaccine would you prefer her to have? You know the two types of zoster vaccine?
I know, but I'm not sure.
It's okay, it's covered in the slide. And then what about pneumococcal? What will you give her? You know the different pneumococcal vaccines?
Yeah, I think it covers like different strains.
So one is 23 valent, is a protein proliferate. The other one is a 13 valent one. 13 valent one is much more effective. So converts it into a T cell dependent and antigen. They induce a memory. So it retains, is a very high quality immune response. And it decreases the carrier of the viral vaccine serotype. Whereas the other one, the 23 valent, is not as potent. In Australia now, those people over 70, they give it to them. I think indigenous, they give even at 50 years of age. So because this one gives you, and even though they had the 23 valent, it's called PPV, protein purified. It's all in my notes. I'll share the screen with you. I think IT can just switch off yours, then I can go in.
Yeah.
All very good candidates are all. Very good. So if you are off the thing, then I go into my share. Okay, can you all see? You can see, Can you see? Okay. Okay, so this is preventive health. There's always preventive health is in any exams. Prevention is part of GP practice. So it's important to know about prevention as well, apart from diagnostic. So osteoporosis, so this is is a bread and butter of GP. So you must know osteoporosis by heart. Like she mentioned, the fracture risk. In Australia, those over 70 now, they use the denosumab. Denosumab is a monoclonal antibody. And you can see here in this graph, the potency. There are no studies beyond 10 years. Other medication, they stop after 5 years. But denosumab, they can go up to 10 years. They're not sure. So this one take a holiday break, but this one, denosumab, they're not sure. So now the studies is about 8 years later. But very potent, you can see. When you compare head to head, you can see they measure vertebral, hip, and non-vertebral. You know the alendronate doesn't not available, doesn't act at all in non-vertebral. Risedronate is 39%. So it's more advantageous to give risedronate. But hip fracture, there are less percentage. And they must all take it on an empty stomach, stay upright 30 minutes, drink water, and also, they must not take like antacids or proton pump inhibitor because they interact with it. Even the H2 blockers as well, they do interfere with the absorption of all these bisphosphonates. And the side effects are the same. That we talk about zoledronic acid, Dr. Dina said. So he said, but you can see the vertebral wrist fracture. See that? So both the monoclonal and zoledronic is given the choice, they are more against the vertebra. You see, you compare vertebral for alendronate, it's only 40%. But given the choice, this one once a year, 70%, why not? So 70%, why not? Unless Malaysia, maybe you have to pay the cost. So 6 months, this one every year, 6 months. And then here, comparable, see that? 40%, 40%, comparable to alendronate. Alendronate is the most effective for hip, but has nothing to protect against non-vertebral. And the side effects, which I mentioned, acute phase reaction, remember I mentioned? Then ONJ, AFF, and uveitis. And this one's got cellulitis and so here is we talk about vaccines. So vaccines is that his Zostavax and Shingrix. So Shingrix is a recombinant vaccine this one is Zostavax is live attenuated, so you can't use it for like immunosuppressed patients. You cannot use it because a live vaccine. This one recombinant one you can use it. So imagine patients who are elderly and then they're going to be immunosuppressed, and then that means they are more prone to get shingles. So all the more that you should vaccinate with Shingrix. Shingrix is not covered under the Australian immunization thing. So this one is covered, but they're phasing it out now. Shingrix, they will give it free when you turn 70 in Australia. I think at the moment it costs about $260 to $300 Aussie dollars. So Malaysia may be about 1,000. But it's look at the efficacy, 90%, even in people aged 80 years old, whereas the Zostavax only 51% and dropped to 38 over 70 years. So the older you see the efficacy drop. How to compare people 90%? This one only 51 dropped to 38%. And then if you after 8 years drop to 44 to 32, this one you persist on, even for 84%, you can go 7 years. So if you have money, you go for Shingrix. Shingrix is more protective, and even exams like this, examiners will look for fine details. If you tell all this, sometimes you impress them, and it's a more of learning and adding on more last minute, just fine tune a bit. If you know a bit, add on a bit, and examiner will be very impressed if you talk a lot on this. So this is the other pneumococcal that we talk. So this is the PPV, they generate antibodies, but short-lived immunity. 13-valent, they use it now. So those who had a 23-valent can have 13-valent as well. And those with 13-valent in Australia, now after 1 year, they can get a 23-valent vaccine. See that? It converts, so it's got that thing, they turn the pneumococcal polysaccharide and then stir up this T cell that induces immune memory. So it's very, very effective now. I don't know in Malaysia, this is Prevnar, they use it in Australia for 2, 4, and I think 12 months old, they use it as a normal vaccine, but later they found that this vaccine is also effective for adults as well. So now they implement this in the adult. Again, you will have to just add on a bit of knowledge to it. Just remember, 13 is better than 23.
Right.
But very well done. Yours is very good. So I'll close this and then I pass it back to our IT support, and then can I have the number 4, Dr. Nuzul, is it?
Yes, I'm here, Doctor. Hi, Dr. Chen.
How are you, Nuzul?
Fine, thank you, Doctor. How are you?
Good, thank you. There's a chat here. Yeah, nothing much. So okay, what's it? Oh, the T. T is for therapeutic inertia. Somebody asked LAST. So L is lifestyle, which is SNAP, smoking, nutrition, alcohol, and physical adherence is for compliance. So either side effect or maybe they don't have enough money to pay in Malaysia or no transport. Secondary causes, secondary diabetic, secondary asthma, secondary hypertension. T is therapeutic inertia. Just like when you work in a group practice, everybody see the cholesterol is high. Inertia is in physics means like you're not, it's people don't take not proactive, So you go and see another doctor, the pressure is like 180, but nobody takes action. You go to see another one is also, you come here 5 visits, so nobody acted on it. That's called therapeutic inertia. Means, it can be you also. If the patient has seen you, but somehow or other you didn't act on it. But if anything medical, legal, they go and sue you, then they say, how come doctor, you never started him on anything, you just let the pressure go on, and then one day you wake up with a stroke, then the lawyer asks for your notes, then they look at, oh, this therapeutic inertia here, you're the GP, you didn't start anything on him, in spite of his pressure detected 5 years ago high, That's called therapeutic inertia. And the other thing is medication, M. So M is sometimes the M is measurement. So the last M, M is important. So measurement. So sometimes like hypertension in the white coat, or wrong calf. So when you got fat arm, you use a small calf, the pressure is high, or you check at home, it's normal, or check in the clinic is high, or the other way around. So measurement sometimes can be diabetic, like they check, they don't know how to do the machine properly, so they may use the wrong method. Okay, let's better go on, otherwise we don't have time. So we go on to the case number 4. Okay.
Okay, Nuju, you ready?
Yeah.
Yes, doctor.
Sometimes the 5 minutes, sometimes they give you clues in it for the case. Sometimes there's no clue, They're just reading, just like to cover, sometimes they don't give a clue. Sometimes there are clues to it. So the 5 minutes, sometimes you sit there for 5 minutes, you read about the thing, you try to memorize as much as possible, but there's sometimes even the record summary is not very helpful. When you walk in the exam hall, they ask you different questions. But anyway, it's a good experience. So Okay. Okay, we start. Nuzul.
Okay, Doctor.
Yeah, morning, doctor. So what other history will you elicit from Mrs. Wu?
Okay, so basically, I would inquire more on the pain using the Socrates mnemonic site of the pain, the onset of the pain, which I already mentioned the stem, 2 months, and characteristic of the pain. Has the pain radiate to elsewhere? And associated symptoms, this is a very important thing that I would ask because she has a history of primary endometrial cancer. I would ask about any weight loss, any loss of appetite, any severe debilitating night and day pain. Is she able to sleep due to pain? Anything that she tried for the pain? And then is there any fever? Is there any night sweats? Is there any neurological symptoms like cauda equina pointing to cauda equina syndrome as well? Is she urinating as usual, or is there any signs of obstructive in her urination? And is there any blood in the urine? And is there any stone in the urine or passing sandy urine? Is her bowel opening or normal? Is there any obstruction in the bowel opening? And then I would ask about the characteristic, back to the characteristic of the pain. Is it a throbbing pain? Is it a sudden severe sharp pain? And the timing of the pain, when does the pain occur? Is it all the time? Is it only during movement and better with rest, or worse with rest, better with movement? And then I will ask about the severity of the pain. If she can she can score from 0 to 10. I would like her to score the pain. And I would also ask about, I would go by system, ask about if she has any headache, any blurring of vision, diplopia, any problem with the vision, any hearing problems, any weakness of the limbs, any reduced sensation of her limbs, probably ask about past history, past history of she has any tuberculosis before, past medical history of tuberculosis. any family history of these spine diseases, like any his family history of spinal diseases, connective tissue disease, inflammatory spine disease. Is she taking any intravenous drug, over-the-counter drug? Is she a smoker, alcohol? How's her diet? How's her physical activity? How's her sleep? Her mental, I would also like to ask about her mental state as well. Is she has depressive symptoms, low mood? And more about her, how is this pain impacted her life? Can she go to work? Or I mean, I would like to explore on the impact of her life on her life. I think that's about it.
Okay, so what are the investigations will you order for Officer's Pool?
Okay, okay. So for office investigation, I would like to order random blood sugar, just to screen her, and just to see how's her random blood sugars like, and urine. I would like to order for the urine dipstick to look for any hematuria, as she has a family history of renal calculi. Blood investigate, and then I would proceed with full blood count to see evidence of anemia from the chronic disease of her cancer, ESR, CRP to see for inflammatory marker. I would order for fasting blood sugar, renal function test to see, and also liver function test to see evidence of deterioration in renal function and liver function, as she has a background of primary endometrial cancer that could point to metastatic disease, microscopic urine, and I would request for actually CT scan. Ideally, request for a CT scan to rule out any metastatic disease to the spine, and an MRI if it's possible to request. Probably tumor markers as well. I would request for CA125.
Tumor markers, are they helpful in this case?
Actually it's she's already been diagnosed. Yeah, I don't think it'll be any help. Yeah.
Yeah, so easier to say baseline investigations, renal, blood count, liver function, and then imaging, we do imaging and X-rays, and then if it's necessary, we can proceed on. Because also sometimes over investigate, sometimes you can be marked down, if you over investigate. Sometimes you have to think about, in reality, I mean, patients' pockets, spend too much money. I mean, of course, it's perfect. It's all like, if you are working as a specialist in a medical center, you probably will order everything. Or in the general practice, you probably order. In Malaysia, because we are paying for our own bloods and all that, unless you're in a government hospital, but still you will not do MRI, CT scan so fast. But anyway, you covered everything. You did everything, you have covered everything.
Oh, okay.
So
Yeah, okay. So should do baseline first.
Yeah.
Okay.
Baseline. So actually, I mean, in actual tech, I would love to give you a few blood film and blood tests to investigate, but because of lack of time, we give you the result instead. So the CT scan was performed and then it showed an osteolytic lesion. And then, so what's your differentials in this case? I mean, this is more coming out from for KFP point of view, I mean, or AKT, but in the real exam, like OSCE, it's it's like an acting, they want you, it's not recall, but they want you to like see the X-ray, interpret, and then that's what the whole is different. With your AKT and KFP knowledge, you got the knowledge, but in the actual OSCE exam is digging out the knowledge and apply to like real actor-like scenarios in general practice. So they will give you a CT, X-ray or something, they probably won't give you this and show you an osteolytic lesion. They'll give you, but osteolytic lesion is easy to diagnose. So what's your differentials in this case? If this if you see an osteolytic lesion here?
Osteolytic lesion could be metastatic lesion from the primary cancer, or could be multiple myeloma as well.
Okay, good. So what are the lesions that give rise to cancer that give rise to osteolytic lesions, like metastasis from where?
From the primary endometrial cancer.
Okay, what are common things that are associated with osteolytic lesion? They come in pairs, thyroid,
Parathyroid.
then the breast, then the lung, then everything in pairs.
Oh, I see. Okay.
Everything in pairs is osteolytic. And then the prostate is usually osteoblastic. Lymphomas also can cause, lymphomas can also cause osteolytic lesion as well. And then there's one type of blood thing they call Langerhans histiocytosis. They can cause osteolytic lesion. So in an undergraduate exam, it's quite, it's simple things, but in the postgraduate exam with low back pain, they can give you one of the examine the back. Initially I thought ask you to examine the back, but in this sort of thing is quite difficult. But they can give you musculoskeletal and all that. So you can get in any exam, then maybe a long case, I give you examine the back. So you must do all your examination of the back. Then they throw some, they ask a history. Then they ask what I asked just now, investigation. Then they throw you a scan, So that is how it works if it's a long case. But because it's 10 minutes, so we'll show you what I have here, and then we'll try to share the screen again. So IT is have to turn off, then I have to go in again.
Yes, you can share now.
You can share now? Okay. Okay, so this is, it actually happened to one of my friends, the brother. So he's 46 years old, he comes with low back pain, and the GP always give Panadol, Nurofen, he went home. Then sometime later, the pain was, but the most important thing, I think, in any back pain is the duration. You look at 8 weeks, is 2 months. So what is it? First, the most important, under your Socrates approach, symptom, the onset is most important. And it's in because you are doing primary care, you're a primary care specialist, so the onset is very important. With the onset, you can, if you know, I used to sit down and write the rules of chronicity, like diarrhea is 2 weeks, urticaria is 6 weeks, chronic cough is 6 weeks. So, things like that. So you chronic cough, I think it's 3 months, 8 weeks, I think there's a chronic cough. So things like that. Sometimes the onset, it tells you something, that is something dodgy here, something is very not right, because the duration too long. Sometimes you don't have to be very brilliant to diagnose. You see, the patient comes, or say, been having cough for 6 weeks already. Then I said, try antibiotic, try this, try that, not that. So it's something there. So they went in, did the X-ray, it was a hilar limb adenopathy, and of course they say you're a good doctor because you diagnose them. Or a patient cough, then we get a history, take the X-ray, say long time, went in, one Thai lady came. So we look in, I said, this is something wrong. I said, take the X-ray, came out as a pneumonia, the pneumocystis pneumonia, and then came out that he had HIV, which wasn't diagnosed when she came to Australia. So the duration is basically very important. I find as a primary care doctor, duration is so important. You look at 8 weeks, in a postgraduate exam, they're not going to give you simple case. It'll be something like this. So you see the duration, you look at this table, acute 6 weeks. We diagnose acute, subacute, chronic. Anything more than 3 months is chronic. Subacute is 6 to 12 weeks. I think you're right to go ahead and do a X-ray in this case, because I know it's 8 weeks already, you subacute, no? And it's not recovering, you see. So you do an X-ray. The X-ray will pick up osteo. So actually, that case, my friend's brother had multiple myeloma, osteolytic spread there, and then missed out by GPs. But now he's basically, I think, it's just palliative care. You know? Then the step 2 is to exclude red flags. You see, in anything is the stepwise approach. So this is the red flag, fracture, FIT, fits, infection, caudal equina. We see that, caudal equina, we see in our practice as well, with, caudal anesthesia, incontinence, urine, bladder, then abdominal aneurysm, then malignant. So these are all the red flags. So first you rule out the red flag, then you talk other things. Then sciatica is the next thing. So sciatica is basically sciatic pain, but sometimes it may not be prolapse intervertebral disc as well. Sometimes you can have a tear of the this tear, but not prolapse. So the inflammatory fluid that pours out can even occlude, put pressure on the nerves. They cause sciatica. And when you do sciatica, you must know, isn't it, the straight leg rising test. And then also is significant even if you raise up to more than 30 degrees. Then it becomes significant. Okay, then you go to the other step, which is non-specific back. These are the common, this is all the date of birth issues, patients getting old. And these are the ones that they have, facet joint, OA. So when a patient can tell me, oh, what's your problem? I say, it's your date of birth. I say, once there's no sciatica, you think of, and you rule out red flags, no sciatica. The next thing is all this common. They say, what's all this date of birth? They say, all this, facet joint, you're getting old, muscle sprain, you do, mechanical, you do too much, repetitive stress injury, and spasm. The last one is most difficult, the rare ones. These are difficult to pick up, because the rare ones are those like stones, renal calculi. They can cause pain. Hyperparathyroidism cause, hypercalcemia. And Cardiac spondylitis more in the upper area, the cervical rather than lower. And SLE and spondylosis can cause. And this you must know a little bit of. If you are given to examine, you must know this. So this is helpful for which surface anatomy. The end specular is T7. Then you measure the PSIS. So you at different levels, you can see what are the surface anatomy of it. And so these are the notes. You can go back and read up. I'm sure you all know all this. And then osteolytic lesion. So this they probably throw you one X-ray and then ask you to diagnose, and then these are the differentials, which Dr. Nuzul has mentioned most of the causes. But remember, these are all PET organs, thyroid, lung, kidney, breast. And so the multiple myeloma, they call it CRAB, C-R-A-B. So the CRAB is calcium, C for calcium, R for renal. But these two are the least common. See, calcium only occurs at 30%, renal only 25%. The AB, the last, is 75%, and bone is 70%. So they got two types of myeloma, monoclonal gammopathy of uncertain significance. That one is 1% turn into multiple myeloma every year. And then the next stage is worse, is smoldering myeloma, smoldering, S-M-O-U-L. That is 50% at 5 years. So you've got smoldering myeloma, you must do this CRAB thing, like measure the calcium, all this renal. Every 6 months you must measure, because the 50% can turn into MM at 5 years. And the last thing is when to screen. So they talk about all this kidney injury and pathological fractures, and most of it is IgG. IgG is the most common, and IgA. Anemia will be normocytic, normochromic anemia, but you must rule out the GIG thing, GI loss, iron, and CKD. So it's a mixture of this. So when you get a low back pain, you can get examination, you can get into, discussing the findings, and we'll try to combine something. It won't be osteoarthritis, it'll be some hidden thing. Okay, let's go to case 5. Yes, interesting one. Who is the next, Doctor?
Me, Dr. Wani.
Thank you, Nuzul.
Okay, thank you, Doctor.
Fifth one is who? Nosha.
Yeah, call me Wani.
Oh, one.
Yeah,
Oh,
it's
how are
easier.
you?
Yeah,
How are
fine.
you?
Thank you so much. Yeah, fine.
Thank you for volunteering as a doctor for tonight. So we give her isn't it? We're giving her now, the IT will give
Yeah,
you,
5 minutes.
okay,
So,
thank you.
yeah. Are you ready?
Yes.
Good morning, doctor.
Hi, hello. Hello, Siti. My name is Dr. Wani. Yeah, it's nice to meet you. How can I help you today?
Just short of breath. I don't know why even I pull the dustbin out the last few days, so I feel tired. I feel like I can't breathe, you know.
All right. Okay, that sounds quite concerning, Siti. All right. Can you tell me more about that, about your shortness of breath? Anything particular that you make it, yeah, that you notice, anything make it worse or no?
When I do a bit of work, which I think I'm quite used to pulling the dustbin out, but I feel tired. And if I rest, I think I feel better. I don't know whether I'm getting old or not, you know, because I'm already 65 years old.
All right. And how long has it been there, Siti?
I think it's been, I don't know, I just like, you know, last 5 months or so, I think I still, though I'm older, I still play a bit of netball and, you know, basketball, and I just feel like play for about 10 minutes initially, or even 20 minutes, I feel good, but now even 10 minutes, I say, oh, I must go and take a rest now.
All right, okay. Okay, besides that, do you notice that is there any fever, any loss of weight or loss of appetite, feeling unwell?
Not really. I don't think I'm hot. I don't feel hot. So I
All
don't,
right, okay. Besides that, do you notice if you have any swelling of your legs?
at times I do have, it's particularly, you know, if I walk, but it's not a lot of swelling lah, but both legs do swell up as well lah. But I think the swelling also maybe worse now the last 1 month or so.
All right, okay. I can see your notes here that you have a past history, but is there any medical illness that you might having right now? Like hypertension, you know, diabetes?
Last time I did blood test was all normal. I did about 6 months ago.
Oh, it was like 6 months ago. Okay. Apart from that, you notice any chest pain?
No chest pain.
No chest pain. Any cough? Any any sputum stained with blood? Nothing like that?
No.
No, okay. And do you have you ever like just recently you being like having change in your environment, like having exposed to any dust?
Don't think so. I just moved to town and I just stay in my cousin's house now.
All right. Okay. Do you notice if at the house having like pets or carpets, thing like that?
Don't think so. I don't think the house quite clean. My cousin look after the house quite clean.
All right. Okay. And do you have any signs or any symptom of like easily bleeding from anywhere else? Like easily bruises, thing like that?
No.
No. Okay. All right. Siti, from your history, I can see that you came today because you noticed that you have increasing shortness of breath, and I can see it's affecting your daily activity, especially when you want to do your netball training and all that. And you also mentioned that you have swelling in your legs. So far, is there anything that you want to tell me?
No, just a bit of lightheadedness sometimes, just a bit like going to faint like that, So I just lie down, I just sit down and I feel better.
All right, okay.
I do some other, walk a bit faster, or maybe my heart beat also a bit fast nowadays.
Okay, all right. Okay. Okay, Siti. There are So there are a few things that I can see that your symptoms probably due to first thing that I'm thinking is about heart failure, because you have your shortness of breath increasing in slowly nature, and you have your pedal edema. You have limbs swelling, and it could be heart failure due to certain conditions such as maybe undiagnosed hypertension, because I can see that you have been haven't done medical checkup for about 6 months. And and besides that, I may also thinking there's other symptoms, like maybe some infections like pneumonia, maybe some anemia, low level of bloods, and also but all these things need to be confirmed with some investigations. Yeah. So do you mind that we proceed with investigation?
So what investigation you will do for CT?
All right. First of all, I would like to do full blood count to see the level of hemoglobin, to look any signs of anemia. I would like also to see the white cell count to see any signs of infection. And then next thing is I would like to do chest X-ray. Particularly, I would like to see any signs of cardiomegaly, and also some pleural effusion to indicate signs of heart failure. And then besides that, I would like to do ECG as well to look signs of any ischemia, because any undiagnosed cardiac disease can cause of signs of heart failure. Besides that, I would like to do echo to look for evidence of, to look the ejection fraction, and also any valvular disease that can also one part of the cause of heart failure.
What else will you look for on the ECG apart from?
Okay, I would like to see any evidence of left ventricular hypertrophy, which can be part of the signs of heart failure as well.
What else will you look for? So it's not for arrhythmias as well, no? Atrial fibrillation is very important for heart failure.
All right, okay.
Very important. Arrhythmias and atrial fibrillation, very important. If the patient, and then in your basic investigation, you should include iron studies to look for ferritin, because there's a difference between iron deficiency anemia and iron deficiency. Iron deficiency anemia means the hemoglobin is low and serum ferritin is also low. No? But in iron deficiency without the anemia, the hemoglobin is normal, but the ferritin is low. No? So if you don't do iron studies, you cannot pick up the iron deficiency. So you must do iron studies as well as the hemoglobin levels apart from full blood count. Just as a routine, you should also do HbA, blood sugar. You did mention blood sugar. Huh? Okay, so if the patient wants to pay for a blood test for heart failure, and she says she doesn't mind, CT say I can pay any amount of money, I want to know, because your echo appointment is like another 2 weeks, I'm happy to pay. Which blood test will you order to diagnose heart failure?
What the name?
You heard of BNP?
Yes, BNP. Yes.
Natriuretic peptide.
Yeah.
Released from the ventricle, so that the volume distends, and then there is release of this this from the ventricles. It's secreted from the ventricles, and sometimes you can get the metabolite is N-terminal pro-BNP, but this one is if there's high, if the BNP often have normal or minor elevations, So if you get a low BNP, you does not exclude a diagnosis of heart failure, the preserved heart failure. No? Okay, so we show if it's a respiratory case, what will you do? What sort of test will you do for respiratory? You can do
For
sleep
if
sleep studies or pulmonary function test, spirometry that you do.
yes, spirometry, PFR.
Yeah. So I'll share this with you and oh sorry, what did I do? Okay, and then the IT support, I need to show them the slide now. Huh?
Yeah, sure.
All right, so this is a shortness of breath is sometimes in the history taking, they might ask about, like you get more history, you know, you can ask about autopnea, paroxysmal nocturnal dyspnea, you ask, you know, in your history taking, just to, paroxysmal nocturnal dyspnea is more or less quite pathognomonic of heart failure. When we have a heart failure, actually we didn't finish that question. So in the heart failure, is the ejection fraction she did, CT did, and it came out to be 35%. So how do you manage, Wani, the case 35%?
So if ejection fraction is at 35%, this is a heart failure of reduced ejection fraction.
Right. So how do you manage her with 35%?
Okay. So first of all, I would like to educate a patient about what is the heart failure. It's basically it's a complication of a certain conditions such as maybe uncontrolled hypertension, uncontrolled diabetes, and so on. So it's very important to educate patient to optimize the control of her contributing risk factors. Okay, number two, I would like also to explain that next, I would like to educate patient on the red flags of heart failure, which is acute shortness of breath, acute pedal edema, and this one patient should come to emergency as soon as possible. Next is I would like to start pharmacological. I'd like to start some medications, which is number one, it's a ACE inhibitor or ARB, and also I would like to start if patient is the failure symptoms is resolved, I would like to start beta blocker as well. And then I would like also, if patient has symptoms, I would like to proceed with I would like to prescribe with furosemide. Furosemide is just to as a relief, it's a relieving of her symptoms. Other than that, in my setting, if patient has a reduced ejection fraction, I would like to discuss further or refer to cardiologist for further shared management, and probably the cardiologist will decide on treatment medications such as spironolactone, or I think I forgot the name. Yeah.
So in any management chronic heart, always start with lifestyle. The lifestyle is, you know, like food restriction, you know, no salt diet, you know, cardiac rehab, you know, these things are just then you go into the pharmacological. But in this case, it's 35% is quite low. So in general practice, these are the things that are common. So I want to share with you common, uncommon, rare. So you must think of common things because like common things occur commonly in GP, you know. So heart asthma, COPD is common in GP, heart failure. So reduce and it's less than 40%. So preserve is the one more than 50. Now there's a new one, mildly reduced, so it's between 40 to 49%. Then anemia or deconditioning, so you're not fit, or overlap means overlap of all these symptoms. Then you should think of interstitial lung, arrhythmias, valvular heart, congenital heart, psychogenic. And these things are pulmonary hypertension, ischemic without chest pain. So in heart failure, they don't present with chest pain, no? Unlike myocardial infarct. So sometimes myocardial infarct can present with shortness of breath without chest pain. So there are sometimes we tend to miss because they don't have chest pain. You assume all chest pain, all people without chest pain is not MI. Occasionally, we tend to miss out as well. Generally, heart failure doesn't have chest pain. They have palpitations, leg swelling, syncope, which is lightheadedness, or in severe, there's syncope, and of course, shortness of breath. So this is a good thing to take back to your practice. You must think of common things because you're a primary care physician, so we think of this. And Wani also asked about, she asked about chest pain, which is very good. She asked about all the red flags. These are all the red flags. This is the blue one. It's a respiratory. This is the cardiac one. And this is the others. So this investigation, you can go and read up yourself. This graph is available to you. The LCO is something to do with the diffusing lung with carbon monoxide. So this is very important. So this is like, you know, is in primary care, the heart failure reserve ejection fraction score is a mnemonic used. They use 6 variables to diagnose 0 to 9. So anything more than 6 or greater, HPEF. Intermediate score between 2 and 5 is actually considered as intermediate, so you refer for specialists. So what's a H2 stand for? Big, I mean, patients are overweight, they're high BMI, hypertension, they use 2 or more. So you're hypertensive and you're overweight, you score 3 points. If you got atrial fibrillation, you score another 3. So 6 points, you already qualify. The patient is very high probability. So this is a very good graph to take back to your practice as well, because it is, because as a, I mean, GP, I practiced in Malaysia also before. I mean, even in Australia, I mean, we are primary care. So we don't, echocardiogram is not freely available. Even in Australia, it takes about sometimes 2 months to 2 weeks to get an appointment in my area. So the H and the F and the elderly, you see. So if you are old, overweight, use 2 hypertensive, and atrial fib, you score 7 points already. These are very important HPA. This is all like, you know, people use that for, you know, there are so many, just like mnemonics in primary care, you know, it's help you to sort of prioritize which patients are likely to have, you know. So we got, so these 2, you need to do echocardiogram, pulmonary hypertension, and feeling pressure. Feeling pressure is the diastolic, the color one, big E divided by small e, more than 9, so you score 1. So this is a good thing that I want to share with you. So this is how it is. If you got 6 to 9, you're almost sure the patient has got. And have you heard of this sort of chart, Wani? Have you heard of this? I find this very helpful. And then these are for the spiral and all that. In your discussion, see that this is mildly reduced ejection fraction. Now they come up. I think once it's less than 50, just remember the treatment is BMAS, so beta blockers. Beta blockers is important, like you say, Lasix to increase the diuresis, but important beta blockers. Spironolactone is used here. More powerful will be spread. epilerone. So this can cause like gynecomastia in males and all that, and hyperkalemia. So be mindful of the thing that you can got hypotension with beta blockers. ACE is normally start, but then if you now the ARNI, if once it's 36%, you must use ARNI. I mean, you start with ACE and then there's a 36-hour washout, where you move over to ARNI. ARNI is a sacubitril with valsartan. Have you ever heard in Malaysia they use this? Sacubitril with, so it's a ARNI, as a, they all
Yes, the
angiotensin
prolicin inhibitor.
So 36-hour washout. So they say stop on Friday and start on Monday, your ARNI. ARB no need to wash out. Because if you change immediately from ACE to ARNI, you can get angioedema. So you must have a 36-hour washout before you switch. This is more powerful. Then now SGLT2 is also inhibitor. They found this empagliflozin is also used. These are the four for reducer. And then once it's 36%, you might use ICD as well. And cardiac resynchronization therapy. So just remember in mnemonics, our Malaysian airline system, B, beta, MAS, MAS. Just remember. So these four must be in for any reduced ejection fraction. You cannot, nowadays, you must start all this at low dose and slowly up titrate over the next 2 months. And then you take out the Lasix, and these four must be there. So the B must be there for reduced ejection fraction. You will lose points if you don't mention any of them. And that's it. So just to share this with you. Anyway, okay, Wani, thank you very much.
Yeah, Dr. Chen, in Malaysia, I think if we have patient with reduced ejection fraction, we normally refer to cardiologist. Is it?
We do refer as well, but sometimes they come back and see us, So that's when I think they expect you to know something because we do follow them up. I mean, in Malaysia, once they go to cardiology, they don't come back to you. But because the cardiologist will follow up the patient. But in Australia, it's different. The cardiologist, once they release, they come back to your care. So you are basically in charge, which is good for us, because we can practice what we have read, and I like the practice in Australia because I read a lot, but I get to practice what I read, rather than just if you don't practice what you read, then you tend to forget. It's like driving a car. You read how to drive, but you don't drive, But now here you get to drive your own car, so it's good. In Australia, it's slightly different, and that depends whether you're in regional practice or in the urban area. Urban area, maybe you don't maybe you don't get to practice all this. We play a big role here. Like regional area, we tend to do a lot more than urban GPs.
Thank you.
I'll see whether there's a question here. Check. What does it say? Oh, okay. I can give you my email. Somebody asked me for my email. So I try to get these slides after you all finish to get to you all as soon as possible. So you can have time to read through the notes. I'll type the email. Okay, let's go on to the next one.
Okay, Sindhu, are you ready?
Yeah.
Yes, yes, sir.
Who's the next one? Sindhu. Oh, thank you, Sindhu, for volunteering. How are you?
Good, doctor. Thank you.
Yeah. Okay, let's start. The last one, I think, should be quick. Okay. Yeah, Dr. Sindhu, this one is no role play here. So you read, did you have a copy of the blood test results as well? Is it?
I only wrote down certain points.
Which one? Yeah. Did you see the full blood
Okay.
count there?
Yeah, HB, MCV, MCH is low.
Okay. So what other further investigations will you order for Sunita?
All right. For further investigation, first of all, I would repeat her full blood count. And also I would like to order an iron study which inclusive of serum ferritin, transferrin and transferrin saturation. Also, I would like to order for if at all the serum ferritin came back as normal, then I would like to proceed with HB analysis to check if she has incidence of thalassemia, any probability of thalassemia. And then yeah, I would also
What's the importance of ordering the iron ferritin studies? What do you expect to, like, what are the things that you expect to see? Like when you order something, you have a motive behind it, isn't it? What is your
yes. So her hemoglobin count is low. So it could be either iron deficiency or thalassemia with her origin as well. So I would like to, the reason why I would like to order for serum ferritin is to make sure if she has got iron deficiency anemia or not. So if she has got iron deficiency anemia, it will be suggestive from the serum ferritin level of less than 15. So if it is less than 15, I would like to supplement her with iron supplement. Probably the current dose is not enough. So I would give her another iron supplement such as Zincofer to treat her iron deficiency anemia, and then further investigate on her thalassemia.
Sometimes ferritin levels can be elevated in infection or inflammation, some other liver disease, or sometimes, so making a diagnosis very, very challenging, So what then will be used? Because you see, how do you confirm whether the serum ferritin is an acute phase reactant? So it can be elevated in inflammatory diseases as well.
Yes.
How do you then, what other things do you do to make sure that the ferritin is more predictive of an iron deficiency?
All right. Okay, since she's pregnant, even if I do ESR, it will be elevated or CRP. And then the rest of it can be through the clinical diagnosis as well, her clinical history. And otherwise, if she has got any bleeding manifestation, and then if she has got bleeding disorders such as von Willebrand deficiency or what, then I could order that investigation. And further would be if there's any.
So what is your diagnosis in this case? What does she have?
All right. So looking at
yeah. So what's your diagnosis now?
Ferritin is only 3, so I would say that she has got iron deficiency anemia. So it is also microcytic hypochromic, and teardrop cell is very typical of iron
Once
deficiency.
transferrin saturation less than 16, they cannot, not enough hemoglobin to make red blood cells. You see, the transferrin saturation is 16 here, no? Once it goes beyond 18 here, once it's less than 16, you don't have enough heme to make hemoglobin. So that's a very important thing to observe, transferrin saturation. Okay, so what is your differentials of microcytic hypochromic anemia? What are the differential diagnoses?
Otherwise will be thalassemia. Thalassemia can also have microcytic hypochromic features.
Yeah.
So to further confirm it with HB analysis.
The mnemonics I use is like a stupid mnemonic, but it helps me to remember iron deficiency. It's the Malay SILAT, SILAT, S for sideroblastic anemia,
Oh,
I for iron deficiency, L for lead poisoning, A for anemia of chronic disorders, and T for thalassemia.
okay.
Just remember the SILAT mnemonic. So how will you manage her? How will you treat this Sunita now? Now
Alright.
that diagnosed iron deficiency, and so she's slightly special.
Mhm. So I would
Why is she special? Why?
she is Thai origin. So first I would inquire regarding her understanding regarding what she's having right now. I will explain her diagnosis probably with the help of a translator, and I would tell her that anemia is very important to treat because since she is early in her pregnancy, so it is important for the health of herself and also her baby. So
How do you prescribe? What are you going to prescribe for her now?
I would prescribe her with oral Zincofer.
Oral what?
Zincofer.
How much milligrams of elemental iron can you?
It has 100 milligrams of elemental iron, if I'm not mistaken.
Okay, all right. What else? How do you advise a patient to take their iron tablets?
Okay, so I would advise her to take iron tablets on an empty stomach for better absorption. And I would tell her that she shouldn't take it with coffee or any milk product of any sort. And then have her breakfast or what after that, after about half an hour of taking the medication. If at all she cannot tolerate the side effect of Zincofer, because sometimes patient can have nausea, vomiting, and bloatedness that makes them non-compliant to the medication. So I would ask her to come back as soon as possible so that we can offer her other options such as Iberad or Maltofer or Obimin.
So at the moment you look at her, she's only on, what is she on? Is she on any iron supplements now?
Yeah, she's on, but only 80 milligrams, if I'm not mistaken.
So that's not enough.
Yeah, it's not enough.
Yeah, good. So other things that can interfere with iron absorption is apart from what you mentioned, calcium also can interfere.
Yes.
Some antibiotics like quinolones or tetracycline, they can interfere. And then the bran or whole grains, they can interfere as well. So how long do you want to take it for? How long would you expect? How long would you give her?
For her, I would like to review her back with a repeat FBC in 2 weeks. And then
how do you know that the patient Sunita is going to respond to the iron? How do you check whether your hemoglobin, you said 2 weeks, that's right, but what do you look for?
I would look for the reticulocyte count.
Okay, very good. Reticulocyte 1 week you can see already. In 1 week you can see the reticulocyte count go up. What about hemoglobin? How long does it take to go up?
Hemoglobin, at least 2 weeks, I think, or
1 to 3 weeks, it can go up. So hemoglobin also can go up, but not reticulocyte is the fastest. Okay, and then what sort of ferritin level do you want to achieve in this case? Like how much of, like if you do the iron studies again?
Yeah. Actually, my target is at least 30 for her.
Okay.
Yeah. So I would tell her that she needs to take this
50 to 100. 50 to 100 is what you will aim for, the serum ferritin. That she doesn't get recurrent iron deficiency, But she's also pregnant. So they basically, if you are history taking, it's either they are not eating, not absorbing, or they're passing out somewhere. So make sure they're not bleeding as well. I mean, initially I wanted to add the history in, but I thought they would take more than 10 minutes. What else can she do? So let's say she can't take iron, she's vomit, she can't do anything. What else will you do for her?
Then I would refer her for IV Venofer. I would give her IV, intravenous Venofer.
Okay, so you will give her parenteral iron.
Parenteral iron, yes.
What is that Venofer contain of? Is sucrose, isn't it? iron sucrose, no?
Yeah.
Can you get a better one than iron sucrose? Because what are the complications with
Cosmoper. I don't
sorry?
know. I'm not so sure of the content. I think it's Cosmoper.
No, actually the best one is Ferinject now. Ferinject is carboxy maltose, no?
Oh, okay.
Yeah, you can just give as a 15-minute infusion. Ferinject, Ferinject is a category B3 lah. So all of them are B3 lah. Your Venofer is also B3, but with the old ones, they can tend to get more like, you know, like other side effects as well lah. With Ferinject, you can get hypophosphatemia, and sometimes you can get risk of allergic reactions as well, and staining, but not as common as IM injections, but still you can get it as well. Okay, if you have to get iron infusion, what are the precautions you will do? Like, do you know of any formula to calculate how much of total dose of iron to replenish your iron source? What do you use? The equation is called Ganzoni equation. It's like an Italian Ganzoni, Ganzoni. So you must make sure that you're calculated and given the right dose. Otherwise, you'll be under treatment of the thing. In Malaysia, how often do you screen pregnant women with anemia? When do you do it?
We screen during booking, and then after that, will be every trimester.
Oh, is it? In Australia, we follow the Australia, New Zealand obstetrics gynecology. It's first antenatal visit, then the next one is 28 weeks. So we screen only twice a year. If it's detected, then you get investigate and treat. So we are more aggressive. We don't normally routinely treat iron supplementation for all women during every pregnancy. So how long will you give for? About another 3 months, maybe, after the thing normalizes.
Oh, yes.
So let's share this again. Let me see. Is that all we asked or something else? Did we miss out anything? I think, let me see. Let me share the slide, then we can talk again. Okay. So IT, can you release, and so I can go in?
Yes, Dr. Chen.
I can go in. There's it again. Share screen. Thank you, Sindhu.
Thank you, Dr.
We'll talk some more when I open up the slides. All right, so we talk about iron deficiency in this pregnant woman. Actually, she's thalassaemic because she's Thai, and you can see the very low MCV in the very relative to the hemoglobin levels, that they concurrently serum ferritin and the MCV are low and the hemoglobin are low. So we manage, these are the test results. So in anything is, once you know, when you get a microcytic hyperchromic anemia, you have to differentiate whether it's anemia or iron deficiency. Iron deficiency, I said the serum ferritin is low, but the hemoglobin is normal in iron deficiency. Whereas iron deficiency anemia is both are abnormal. Then you got to rule out differential diagnosis, which is the SIRAT thing. But copper also can cause a low iron deficiency as well. Then look for the causes, decreased absorption, decreased production, and increased excretion somewhere, either through the urinary or through the anal area as well. Then we talk about oral iron, parenteral iron. Decreased treatment in pregnancy is special. You treat for at least 3 months, and you aim for serum ferritin of 50 to 100. Assess the response. You look, reticulolysis takes 1 week. Hemoglobin takes like 1 to 3 weeks to normalize. So you can see very low serum ferritin. Once is what doctor said earlier was right. She said once it's less than 15, in fact, you can more or less say that the patient has iron deficiency anemia, and total iron binding capacity will start to increase as the hemoglobin drops. This is the one that's going to differentiate this and so when this is increased, this is not is not affected by chronic inflammation. So in chronic inflammation, ferritin can go up because the acute phase reactant, but the soluble serum transferrin receptor is not affected. If this goes up, it's indicative that the patient has iron deficiency anemia. Apart from what the doctor said, symptomatic, so you got fever and all this arthralgia, arthritis, then your ferritin also will go up. Clinically, you can make out. But laboratory, you can do a soluble serum transferrin receptor to differentiate an iron deficiency from an inflammatory or infection. And they're always microcytic hypochromic. The causes are CLAT. MCV is less than 80, and MCH. But the other thing, if severe, not in this case, but if severe case, you look at iron deficiency anemia, sometimes the thrombocyte, the platelet count can be increased, So you can get thrombocytosis as well with iron deficiency anemia. The white blood cell count won't be affected, but in this case, the platelets are normal. But in severe iron deficiency, there can be thrombocytosis as well. And then other things like, so when you put parenteral iron, there must be indication either they're not tolerating or they are not absorbing, or severe, they lose a lot of blood, or iron reactions. Then you must not have total iron treatment for 1 week after the infusion. Then you must use the appropriate Ganzoni equation to calculate. The other thing is iron fractions in treatment in pregnancy must do in Australia is first antenatal and 28 weeks. So know what is done in Malaysia as well. And then you need same 100 to 200 milligrams. But if deficiency, you don't need such a high dose, you use only 20 to 80 milligrams. And you continue for 3 months minimum after hemoglobin normalize or 8 weeks postpartum. And if it's still less than 100 grams, then you do it for 3 months. Then the response to treatment we already discussed. Iron replacement treatment after correction anemia continue for 3 to 6 months in adults. And so one of my doctors, registrars, they got iron deficiency anemia as a long case, and then they wanted to they want you to diagnose celiac disease, on top of it. So it's quite a difficult case. My registrar was quite upset that he passed the exam. He did well in the other short cases. He failed in the iron deficiency, and then there's another exam, the same exam. They give you 2 short cases. One is anemia with celiac anemia in children. Then go to the next station, anemia in pregnancy. Two anemias in one exam, which is a bit unusual. So it's good to know. I mean, apart, we are doing it not just for past exam, but for our everyday practice, because it's quite common. So we tend to should know a bit more about iron deficiency, which is the most common cause of anemia in general practice. So I could try to go back to the chat and then fill the Google form. What else is there? Yeah, so I'll be doing a bit of, what's the SILAT? No, not SIRAP, SILAT, S-I-L-A-T. S-I-L-A-T, not SILAT, the Malay SILAT, S-I-L-A-T, S for sideroblastic, I for iron deficiency, L is a lead poisoning, A is anemia of chronic disorders, and T for thalassemia trait. Thalassemia, thalassemic. thalassemia. So yeah, so I think yeah, then my registrar, Zina, and then yeah, so happy to meet up all of you. I don't know, I think they are not all exam, but some are doing other courses, or some are pharmacy, or some are some of my friends and some of my patients as well in the crowd as well. So thank you very much. We try to get the slides to all of you within the next 1 or 2 days. And then I hope you learn something from it. I also like to do, so I did a lot of, my interest is teaching family medicine, so I do a lot of YouTubing as well. If you're interested, go to my channel and have a look. I did one on hypertension. I got 2,000 viewers in 2 months. Next one I speak is cholesterol, and then yeah, so it takes about 4 or 5 months to do one because of workload and that. So if you have it, then you can subscribe. To subscribe means you don't have to pay anything. You just subscribe, then YouTube will notify you of my next you know, like, oh, he's saying Dr. Chen is taking something on gout now, so you all can then go into the, instead of me harassing you all and say I've got a new production coming, new video, you all will be notified. So any more questions, any more to ask? Otherwise, those who are sitting for exam, good luck. Those who are not sitting, they can always use it for their practice. Those medical students also, I'm sure there are some medical students, because this one is not just for exam, for everybody to learn. And there are some senior examiners, senior doctors here as well. So we are sharing just to share information. And every time, like I said, the best learning tool is to teach. So when you teach, you learn and memorize, because you don't want to be a fool, but to be make a fool in front of everyone. But when you read, you absorb 10%. You read again, you absorb 5%. But when you teach, you will know everything. So this is my website on the YouTube. Actually, I'm promoting my YouTube. So you all can go. I don't earn any money from it. It's just for the fun of it. And so good luck to everyone and good night. It's almost 11 o'clock in Australia now. So I'll be, yeah. So any other questions? You got my email, and my email is Tim, THIM, at thewellnesshouse.com.au. So Tim, capital THIM, Tim Chen, the Tim at the THE, and then my medical center is called Wellness House, WELLNESS, and then house, HOUSE.com.au. And I thank all the organizers. I thank the IT people who help me. They are anonymous. They're very shy people, but they're good friends of mine, so they help me to do up all this. So thank you very much for everyone to attend, and good luck in your exam and good luck in your practice. Yeah, that's right. Team at the Wellness House there. Oh, it's got a lot of message chatting. Thank you. So I'm happy to do one again. I mean, if you're interested, sometime maybe more, maybe 1 or 2 topics, not so long, 3 hours. But maybe 2 topics or 2 topics in 1 month, not so bad. It helps me to read as well. So and this keeps my brain going. So thank you very much. All right, thank you. Good night.
Thank you, Dr. Chen. Good night.
Thank you to all of you. I will probably want to meet up with the IT later and find out how I'm going to send this thing. I don't know how I'm going to send it. IT, how we send it? WhatsApp or what? How do we send my slides over to everybody? Got 6 case summaries here. Everyone's got their email. I don't know how to send, otherwise I can send it now also. email participants that registered and joined today. Yeah, I think that. Yeah, all right. We'll sort it out at some station with my 2 IT support people. How to get my slides across to all of you. Okay, good night. You can do the feedback if you all want for the talk. Fill up that feedback, so we can have what are the ways I can improve my